What if you thought you had a killer idea that looked good, sounds good, and people actually told you it was good, but it never quite got off the ground? What would you think then? Hi, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On Viral Healthcare, we explore the trends and ideas that are spreading across healthcare and learn how to implement them wisely, effectively, and sustainably. So today I want to reflect a little bit on what we talked about earlier this week on an activity, a program that I was involved with, directly involved with, that we thought was great. And it had wide uptake until we looked a little deeper to find out what was going on. So let me set the stage. It was 2016. There were so many projects going on in healthcare, so many things that were asking people to get better. And the burden often fell to the nurses. It was weird. They had to write all these checklists. They had to do all these assessments. A lot of them were manual because EHR penetration was kind of uneven at the time. And so with all this pressure, it felt like each one of them was valuable. Each one of them had some science-based background behind it, but together, cumulatively, it kind of was a big burden administratively. And they asked, is there something we can do that simplifies and yet accomplishes the same thing? So we came up with, as a team, and we worked with the American Hospital Association to promote this. It's called the UP campaign. And there were three components: wake up, get up, and soap up. So let me talk really quickly about what they were. Wake up was to reduce oversedation that was happening with benzodiazepines and opioids. And so we thought if we could reduce that, we'd create and have a lot of impacts on several different problems going on in healthcare. The second one was get up, and that was early mobility, early ambulation in the hospital. And that has profound activities both on delirium, on energy level, whether people have urinary tract infections. It just was incredible. Just getting people up more often was super powerful. And finally, soap up, which you probably already know has to do with hand hygiene. And man, how many infections and things that would be better if we were much more effective at how we did those kinds of activities. So there was a lot of components, but we simplified it down into a very easy to understand, easy to explain, and easy to identify with campaign called the UP campaign. We spent months coming up with it to figure it out, to get it just right. We even had a phrase that if you just said, every time a nurse goes into a room with the patient, asks the question, is my patient awake enough to get up? And just those simple questions like that would sort of prompt people to be able to do it. It was a hit. It was a hit. Along with American Hospital Association, we promoted it to over 1,700 hospitals. We were on national webinars all over the country. We were on state webinars. We went in person to state meetings, hundreds and hundreds of hospitals heard our team. I went into individual hospitals to promote it at large health systems and in those kinds of settings. So really a huge uptake. And why was it so popular? Because it made sense. It was conceptually very ideal, very easy to understand. And people just thought, this gets us back to why we became a nurse. This gets us back to what we're all about. And it undoes some of these tendencies we had to kind of keep people quiet and keep people in bed for a whole bunch of sort of justified reasons, but they sort of saw the idea of working on this would have been fantastic. So let me fast forward and let me just say that it didn't take off. It took off conceptually, but operationally, we just didn't have it worked out, to be honest with you. We were trying to avoid this concept of adding measures because hospitals told us we already had too many measures. So we really didn't get good ways to know whether it was actually being implemented and implemented well. We didn't have an overall aim. We hadn't figured out some operational details like on get up, who's supposed to do that? I mean, we had an answer, but we hadn't really worked out how that happens and how you really implement something like that effectively. So it was additive work because nothing was removed and it was not operationally well defined. So after 2 years, we stopped promoting it. And this was after thousands of presentations, thousands of people saying, this is why I got into healthcare. It just didn't work. So this is a mea culpa. I wanted to be able to share an example of something that went viral for all intents and purposes, and yet didn't really accomplish what we'd hoped it did. It was a great idea in concept, and operationally, we just weren't ready. We hadn't worked it out. and the health system wasn't able to do it. So before you add another topic, another innovation, another great idea, even if it sounds great, even if it gets to the core of why you're in healthcare, ask yourself this: are we really operationally ready to do it? So that's our reflection this week, and I'm looking forward to next week. We're going to have a guest. We're going to be interviewing a person who's done a lot of work with leadership coaching, and we're going to learn about how different leadership styles impact the ways we think about decision making and how we go about deciding whether an innovation, an idea, a trend is something worth trying in our organization. So until then, I'm Bruce Spurlock, and I will see you next time.